In the last class, I did talk about the respiratory graphics and basic concepts of mechanical ventilation so that you will understand the modes better. I hope all of you remember what I have talked about. A part of it may be repeated today also. A part of it may be also repeated today. So it's a kind of trying to add up to the concept so that it gets reinforced in your mind and you tend to remember the concepts well, and you'll be able to direct and take care of the patients at the bedside. So if you look at the equation of motion for mechanical ventilation, the amount of effort the patient puts, or the effort, muscular effort he puts, is to overcome the resistance and the compliance of the alveoli. See, if you want to draw air in, so you have to overcome the resistance of the tubes, which are all represented in this figure. To conceptualize, all the airways have been put into a tube. So he has to overcome the resistance of the tube and the compliance of the balloon. So this is the stick and balloon representation. Though it may not be very accurate, to conceptualize and understand mechanical ventilation, you can keep the lung into this kind of a model, like a balloon and a stick model, where balloons represent, one balloon represents all your alveoli and the stick represents all your airway. So if somebody has to draw air in by contracting his diaphragm or the inspiratory muscles, if he is not capable of drawing air with these two, he may recruit the accessory muscles. So this is what he has to overcome. If the patient is capable of doing that and managing his blood gas as well, probably he doesn't require to go on a ventilator. It's an obvious deduction, isn't it? That's not difficult to understand. Whenever this also can be put into elastance into volume also. That is the elastic load and this is the resistive load. Whenever the patient is not capable of creating that effort, or his effort is not capable of maintaining the blood gases, we add up a ventilatory assistance. Now there are two components now. If you look at the ventilator puts in a pressure and patient also tries to put in a pressure. So this is what you have to understand. Now if the patient if the patient is paralyzed, who is going to take up the load? Tinson, who is going to take up the load? There are only two components now. One is the patient and one is the ventilator part. If during anesthesia you have paralyzed the patient, who is taking up the load of overcoming the flow resistance and the elastance? Ventilator is. So looking at what is the patient capable of contributing to the effort to overcome this, you have to decide which is the mode. If you ask me which is the mode for this patient, my answer would be to you to see your patient. The patient is able to generate some effort, probably can be an assist mode. If for other reasons you paralyze him, you put him on a muscle relaxant for anesthesia purpose, then the whole assistance has to be provided by the ventilator, isn't it? It's obvious. So whenever you have to decide which mode to go along with for the patient, you have to look at your patient and see what is the capability, how much load can he take. The rest has to go to the ventilator. It's an obvious deduction. It's not rocket science. Depending upon the clinician's assessment of the patient's capacity to take the respiratory load, the rest of the load can be given to the ventilator. This is how you decide a mode, isn't it? See, in anesthesia, you paralyze the patient for a different reason. You want him to be quiet. You want the surgeon to have a comfortable patient to operate. Then who takes the load? Dr. Nisha, who takes the load? Obviously, isn't it? You say post-operatively, you give a relaxant, but the patient is cold, is not breathing well. What is the kind of mode you would like to go? The patient is capable of generating a breath, but is not capable of breathing very well. So you go with a you may go with a mode where patient takes a small load and the ventilator takes a more load, isn't it? That's how you decide how to go with a mode. You understood that concept? There are only two components, patient and ventilator, and what they have to overcome, the resistance and the elastance, so that the gas exchange occurs. If the gas exchange doesn't occur properly, with the patient's effort alone, you add up a ventilator. Then you look at your patient, how much load can he take? The rest goes to the ventilator. That's how you decide which mode to go ahead with. Understood? Okay. So what does a ventilator do? I have done this in the first class. Ventilator just produces a
inspiratory flow of gas.
Isn't it? That's what it does. It doesn't do anything other than that. A ventilator produces the inspiratory flow of gas. And I've said you can limit only one of the two things. What are the two limitations you can put to the flow?
Volume or pressure.
If it is pressure, we call it as, if it is volume, we call it as volume limited mode. If it is pressure, we call it as pressure limited mode. That much is clear. Meaning, I can tell the ventilator, deliver 400 ml of tidal volume. It delivers 400 ml of tidal volume irrespective of whatever your resistance is, whatever your compliance is. What is the variable then? What can vary depending upon the resistance?
The pressure can vary.
What are the pressures we normally see?
Pressure and the flow.
Flow cannot change. Flow is fixed in a volume limited ventilation. Flow is fixed and volume is fixed. I have told you in the first class, volume flow into time is volume delivered. When we say volume is limited, flow also is limited, isn't it? It's fixed. When you set the clinician sets 400 ml, it is fixed. Now it is going through your tubes and your alveoli. So what can change depending upon the compliance of your lung or your resistance?
The pressure can change.
So what are the pressures we normally see to assess that? What are the three pressures which I taught you?
Peak inspiratory pressure.
Okay. Plateau pressure and driving pressure. I'll come back again so that you will have a better understanding. The other way is you tell the ventilator, you deliver a flow till 20 centimeters pressure is achieved in my alveoli. You tell the ventilator. So when the ventilator starts pushing, if the resistance increases, what decreases? What is the variable in a pressure limited ventilation? What can change?
Volume.
You understood? Volume can change. That's what you have to remember. Now, this has a square wave so that the flow is fixed. If the patient wants to increase the flow, it doesn't give. It's a fixed flow. So it is not comfortable to the patient. A volume ventilation has a fixed flow. So it is not comfortable to the patient. Meaning, a volume ventilation should be only used when the patient is passive. When the patient starts breathing, it is not comfortable because the flow is fixed. And when we breathe, when we start our inspiration, we tend to draw maximum air at the beginning of inspiration. This is how your pressure ventilation happens. So it mimics your normal breathing. It is more comfortable to the patient. So whenever patient starts breathing, always shift the patient from volume limited ventilation to a pressure limited ventilation. Understood? Because the flow is decelerating, meaning till the pressure is reaching 20 centimeters, the flow is more. Once the pressure reaches 20 centimeters, it doesn't want to give more flow. It starts decreasing the flow because the pressure is preset. It can't increase the pressure more than 20 centimeters. Understood? So, in a volume ventilation, the flow is fixed. In a pressure ventilation, initially the flow is high, then it decelerates. So it is more comfortable to the patient. Now, another thing what I have added up is the ventilator is capable of only producing 5 modes. You remember this, only 5 modes. And all the newer modes are based on only these 5 modes. I think Dr. Jayashree's audio is disturbing. Dr. Jayashree, I think your audio is disturbing. I think you have to mute your audio. Yeah, thank you. So now the ventilator has capabilities of only producing 5 modes. Only 5 modes. All your new modes are based on these 5 modes. What are the 5 modes the ventilator can produce? These are the 5 modes. What are the 5 modes? Volume control, assist volume control, pressure control, assist pressure control, and pressure support. Pressure support ventilation is also called as continuous spontaneous ventilation in some books, but let us keep a clarity and just leave it at that and we'll call it as pressure support. The ventilator is capable of limiting only 2 factors. One is volume and one is pressure. And it is capable of producing only 5 modes. And all your new modes are based on these 5 modes. So once you understand these 5 modes, you can deduct and understand all the newer modes. So what are the 5 modes, Tinson?
Volume control, sir.
Hmm.
Assisted volume control, pressure control, assist pressure control, pressure support.
Which is the mode in this with a square wave or a constant flow?
Sir, volume control and assist volume control.
Okay.
Both of volume.
Which are the modes which have a decelerating flow?
This pressure control, assist pressure control, as well as pressure support also. Both the 3 of them have decelerating.
Which is more comfortable to the patient? Volume limited or pressure limited?
Pressure limited is more comfortable, sir.
Why?
Because the decelerating flow pattern is mimicking the physiological breathing pattern.
That is not the answer. Initially, till the pressure is reached, the high flows come. When we start our inspiration, we tend to draw more air in, isn't it? So that is how the pressure limited ventilation works. So it mimics your normal breathing. That's why it's more comfortable. So you tend to keep volume limited ventilation only in patients who are passive. Not when somebody starts breathing, it's not comfortable. Always you tend to change it to pressure limited ventilation. Understood, Nisha? Any doubt
Yes,
in
sir.
this?
No.
So what are the 5 modes the ventilator? Only 5 modes the ventilator can produce. Dr. Nisha.
Sir, the volume control, pressure control,
Your audio is not visible.
assisted pressure control.
Yeah, and pressure support. These are the only 5 modes. Okay, right. So when we think of basic modes and when we tend to ventilate patients, we only look at 3 components. One is safety of the lung or safety of the patient, comfort and liberation. The question is, do these modes provide all 3? Do we have to look beyond this? Do we require any new modes? Will these modes do all the work is the next question, isn't it? See, when you are looking at safety, only 2 modes we generally use, whether a pressure controlled ventilation or a volume controlled ventilation, and in rare instances in ARDS we may use a APRV.
Yes.
Otherwise, most of the mechanical ventilation is used for providing comfort and liberation. And the newer modes may outscore the older modes in comfort and liberation. But do they make really any difference to the patient outcome? There are no great studies, but it may make your life easy because there are modes which are automatic. They themselves wean the patient out. There are some very physiological proportional modes which give more comfort and go for easy liberation. So when you look at that part where the manpower capabilities are being tested in times of COVID, probably newer modes may outscore the old modes. But if you have time, if you sit near the patient, if you are capable of managing the settings, most of these modes can provide safety, comfort, and liberation. Understood? Just because you don't have a fancy mode, don't think you can't ventilate a patient. And in fact, most of the studies have proven that more than 80% of the patients in the ICU are always on the basic modes only. So the work can be done. It necessarily doesn't mean that you require to have a fancy mode. As I have said, all your fancy modes are based on only these modes. Okay. So what is the disadvantage of a conventional mode? See, as a clinician, you assess a patient, you set the ventilator. What happens is, once I say I give 400 ml, if the patient requires more than 400 ml, it doesn't change unless you go back, see the patient and change. So what happens here is the patient has to adapt to the ventilator. There is no looping of the information from the ventilator to the patient so that changes can occur. It's a fixed thing. All the basic modes, once you set a parameter, if you don't go and change, the same thing keep going. See, I'll show you an example. See here, this patient is on a OP poisoning, day 4, stable on a pressure support mode. What is the pressure support here?
10 centimeters.
What is the tidal volume is getting?
It's getting 400 ml.
Okay. See, now what has happened? The lung was like this. Now suddenly there is a sudden increase in secretion. See, lung has become like this. What will happen now? In a pressure support mode, what will decrease?
Tidal volume will decrease. Okay.
So you have to increase the pressure support to 14. Otherwise, the patient will start hyperventilating. You understood? This is what happens. You go to a advanced mode, like a volume support. The pressure support from 10 to 14 happens automatically. The mode is built like that. In a volume support, we tell the ventilator you can operate between the pressure of X to Y, and we want a tidal volume of 400. So if the 400 becomes 300, automatically the tidal volume increases. The pressure support increases and tidal volume is kept constant. That is the difference between an advanced mode and a basic mode. In a basic mode, once you keep a pressure support of 10, whatever the tidal volume, if the compliance increases, if the lung was like this, becomes good, the tidal volume may go up to 500, where we have to decrease the pressure support. It doesn't happen. You have to go see and do that. In the newer modes, this happen. You understood? That is the better part of newer modes. Not that anything different to the patient will happen. It will give more comfort to the patient, more safety to the patient, and you may go for earlier liberation, isn't it? Going and standing in front of a ventilator 24/7 is not possible. So we tend to, we have innovated newer modes where the pressure support changes when we give a target of 400 and we give a range of pressure support to operate. That is your PRVC or volume support or mandatory rate ventilation or mandatory minute ventilation. All those modes work like this. We give a pressure range and a target of tidal volume. Whenever the compliance decreases, the pressure support goes up or pressure control goes up. Whenever the compliance increases, becomes good, the pressure support or the pressure control starts coming down. Those are the newer modes. These are the disadvantages of old modes. But if you are capable of standing there, spending your time and changing, probably there won't be any difference to the patient outcome. So what are newer modes? When this is the limit variable, this is the only possible output from the ventilator, only 5 outputs the ventilator can give. And when you set it to a target, like a tidal volume, like a work of breathing, then you get an advanced mode. So basic mode with a targeting scheme becomes an advanced mode. But what you have to understand is all these modes are based on a volume limitation or a pressure limitation and only 5 modes. So if you understand the basic pressure control, assist pressure control and pressure support ventilation, and I also include SIMB. Because all of you are fascinated and think that is the best mode that is possible, I will prove to you that it's not a very good mode and it is a mode that should be removed out of the ventilators. And many newer ventilators are not being promoted as a part of SIMB capabilities because it's not a mode which is very physiological to the patient. I'll tell you why and I'll convince you to that effect. And when we talk of ventilator and modes, don't forget, whatever you said doesn't work because brain has its own inspiratory time and expiratory time. And just because you set on a ventilator 400 ml IE ratio of 1:2 and a rate of 12, it doesn't mean it synchronizes with your neural inspiratory time and neural expiratory time. So this component has to be factored in always. So when the patient starts fighting, you have to think, what I have said and what the brain wants is not syncing. So something is going wrong. So when we talk of ventilator, don't think everything can be done correctly or all the pathology of the patient can be corrected by setting your ventilator. It doesn't happen. Always the patient's neurological drive, respiratory drive, and the neural inspiratory time, neural expiratory time, and the amount of volume that drive requires to correct the blood gases has to be looked at when you set the ventilator. When you set the ventilator, when there is hypoxia or hypercarbia, you should analyze, okay, this is not what the body wants. Body wants more. So I have to go up on the support. So this is what, always remember this. There is a patient component also. Don't always think you set the ventilator, it works. It doesn't work that way. Okay. So basic modes are actually only five modes, but For completion, I've added up SIMV also, but SIMV is a mode which is a combination of either volume support, volume controlled and pressure support, or pressure controlled and pressure support. It's a combination mode. It's a combination of either one of the two. So it's not a mode by itself, it's a combination mode. So we don't consider it as a part of the output. You can consider as the first advanced mode, SIMV as a first advanced mode. As I have said, looking at the patient's work capability, the rest of the work has to go to the ventilator. To one end of the spectrum, when the whole work is taken by the patient, we call it as CPAP. When the whole work is taken by the ventilator, we call it as controlled modes, isn't it? Ventilator, when the patient is paralyzed, it's in a controlled mode. When the patient is breathing spontaneously, they are in a spontaneous mode. In between are your pressure limited and pressure support modes. In between are the modes that you give the patient in between. So whenever you on a ventilator, if you put a mode button, this is what you get it. This is a screen you get. One is non-invasive or invasive. Then you have to put the invasive button. Then you have to choose. See, pressure or pressure control or pressure assist. Volume control or volume assist. Then SIMV, then pressure support. These are the basic modes you get in any ventilator. So you have to be aware of this screen. Whenever you touch the mode button, this is what is displayed in most of the ventilators. Then you have to choose. As I have said, if the patient is paralyzed, what is the mode you will choose now?
Control.
Volume control mode, sir.
Yeah, you can choose a pressure control also, isn't it? Volume control or pressure control you can choose. The patient starts just capable of breathing. What mode do you choose?
Assisted.
Yeah, assisted. Whenever patient starts breathing, it is always better to go in for a pressure assist because the flow is better for the patient. Synchronization is better. So when patient is paralyzed, always volume control would be a better option. When the patient starts breathing, pressure control, assist pressure control is better. When the patient has a good capability, always go with a pressure support and then plan for extubation. This is the basic modes usage. SIMV is a mode which should not be used. I will tell you why. We'll go there, but this is how the panel looks. You remember this. This is how the panel looks. So what does a ventilator do? What is the only thing a ventilator does?
Provides
Generates inspiratory flow of gases.
So what are the two limits the flow can be set to?
Either volume or pressure.
What are the 5 modes that can be a ventilator can produce?
Volume control mode, pressure control mode, volume assist mode, pressure assist mode, and pressure support ventilation.
What are the 2 types of flows that it produces?
Either constant flow, which is provided in volume control mode, or a decelerating flow, which is provided in pressure control mode.
Understood?
Yes, sir.
This clarity should be there. That's why I'm going slow here, so that you people understand, because all of you have a confusion. Let us make it clear. Once you understand these 5 modes, all the modes on a ventilator is understood. You can be sure that you will understand. Once you go and deduct, you will understand. Okay? This is the basic concepts. So this is a gentleman who has made a classification of modes. So let us give the credit to Dr. He's a respiratory therapist. He's a respiratory therapist of par excellence. There are in fact 175 modes on different ventilators. But when you group the way Chadburn has made the classification, it comes to almost only 12 modes. You can narrow it down to 12 modes. So to clear the confusion, compare and study. It is very important. So he is the guy who has made the classification, who has popularized the classification. So these are the problems. Same names, different modes, different names, same mode. So there are a lot of complications because of the trade people. They go and register and make it as their company's copyright. So the other guy manufactures the same mode and labels it differently. So we get confused. So whenever you see a mode, always look at the basics. What is your analysis of that mode? Then you will place it in the one of the 5 modes. So there is no confusion. Okay. So how do you define a mode? You can define the mode by 2 things. One is, what is the control variable within a breath? Meaning, who starts the ventilation, who limits the ventilation, and who cycles the ventilation from inspiration to expiration. This is one part. You have to analyze this first. Then you have to see what are the breath sequencing. Is there any control and pressure support together? Or is it changing from control to support to in a given period of time, after a given period of time? So once you see this sequencing, only mandatory breath or mandatory and assisted breaths, mandatory with spontaneous breaths. Once you see what are the type of breaths you have in a 1 minute time, then you can analyze what is the mode. So two things you should always remember. What is the control variable within the breath and what is the breathing sequence. So we will try to understand this now. Okay. So control variables are 3 questions, always 3 questions. What are the 3 questions you should ask yourself?
What starts the ventilation, what limits it, and what cycles it?
So who limits? What are the limits placed on for the inspiration? We have already finished that part, isn't it? What are the 2 limits?
Flow limit and pressure limit.
What are the 2 limits for the inspiratory flow you can set on a ventilator? We did discuss that, isn't it? See, ventilator produces only inspiratory flow and you can set only 2 limits. What are the 2 limits?
Flow and
Pressure and
pressure.
Volume and pressure, isn't it?
Yes.
This we have already discussed. So one part of the question is already answered. What are the limits to the inspiration that a ventilator can be set to? Tinson.
Volume and pressure. Sir.
Volume and pressure, and we have discussed in volume ventilation, pressure changes, and what are the pressures you have to see. In pressure ventilation, volume changes, and how to look at the volume, tidal volume we have seen. So one part of the question you have already understood, and we know that. Now only 2 things we have to understand. Who triggers the inspiration? We'll go there.
Flow,
Yes.
sir.
Huh?
Ventilator, either the patient or the ventilator.
Okay. So this part we have understood, isn't it? This we have already discussed, isn't it? Ventilator generates the inspiratory flow of gas. Flow occurs till a volume, set volume is delivered. Flow occurs till a set volume, pressure is achieved. Pressure is decelerating flow. High flow initially mimics normal breathing. This is fixed flow. Patient may not be comfortable. So here the variable is pressure. So what pressure? Peak pressure, plateau pressure, or driving pressure. Here, what is the variable in pressure limited ventilation?
Volumes.
Oh, so you look at the volume. This part is understood, isn't it?
Yes, sir.
Dr. Anbumani, any doubts on that?
No, sir.
Dr. Nisha?
No, sir.
Okay. So one part we have answered. Limiting is always done by the ventilator. Limiting is always done by the ventilator, and there are only 2 limits. One is volume limit, one is pressure limit. And we have understood that concept. So now let us go to the triggering part. Triggering is, these are the 3 questions we always ask. So who can initiate a breath? There are only 2 components. So who can initiate a breath? Nisha?
Either the patient or the ventilator.
Obvious, isn't it? It's not a very difficult deduction. Either the patient has to start a ventilation or the machine has to start. So how does the machine know when to start? How does the patient communicate to the ventilator that you give me a breath? That's what we have to learn now. That is called the trigger variable. Let us learn that now. And cycling, see, this is the limiting part that we have already learned. Cycling is a component which is called that change of inspiration to expiration is what we call it as cycling. Again here, only 2 components can change from inspiration to expiration. One is patient and one is the ventilator, isn't it? So this is called cycling variable. This is trigger variable. This is limit variable. Limit variable we have already learned, and it is always done by ventilator. Okay, right. Let us learn the trigger variable. And remember, pressure support is the only mode which is triggered and cycled by the patient. All other modes, cycling is done by the ventilator. There is only one mode where the cycling is done by the patient, and that mode is called as pressure support. You remember that. I will teach you how the cycling occurs. But there is only one mode where the patient can start a breath and change from inspiration to expiration, and that mode is called pressure support mode. 2 phases of the three components are controlled by the patient. So it is more comfortable to the patient. In fact, pressure support is the mode, I would say about 80% of the time the patient spends on a ventilator. So you have to understand pressure support properly. That's the only mode which allows the patient to change from inspiration to expiration. Understood? In all the other 4 modes of the 5, the ventilator changes from inspiration to expiration. Understood? Which is the only mode where the patient can initiate a breath and change the inspiration to expiration.
Pressure support.
Understood? Okay, I'll teach you what it is. You just remember that. We'll skip this slide. This is called trigger variable. Patient is placed on a ventilator when his breathing is not capable of maintaining blood gases, isn't it? So how does he start a breath? How does the ventilator start a breath? If the patient is paralyzed, how does the ventilator know when to start a breath?
So we set the respiratory rate.
When you set a respiratory rate and IE ratio, say if I set a respiratory rate of 10, IE ratio of 1:2, so how many breaths you will get? If I set a rate of 10, if one cycle time is how much in a respiratory rate of 10?
6 seconds.
So that meaning every 6 seconds, ventilator knows that it has to start a breath.
Yes.
So how does it know? By elapse of what? Time. So how does the ventilator know to start a breath? It's always by the elapse of time. Understood? If I make the rate as 20, then how fast will the ventilator start a breath?
Every 3 seconds, the ventilator will provide us.
Understood, Nisha? If I increase the respiratory rate to 20, what will be the cycle time? 60 divided by 20. What will be one cycle time?
3 seconds.
So every 3 seconds it will give a flow. Every 3 seconds it will give a flow. So ventilator can start a inspiration or initiate inspiration by elapse of
3 seconds.
time, looking at your IE ratio and your respiratory rate. Understood?
Yes.
Now, how does the patient communicate and tell the ventilator, I want a breath? He has to trigger. So that is, there is something called a trigger on a ventilator. So there are 2 types of trigger. What are the 2 types of trigger?
Pressure trigger and flow triggers.
So let us understand what is pressure trigger and what is flow trigger now. So if I set a trigger of 0.5 centimeters, if the patient's diaphragm contracts and he generates -5 centimeters of pressure, the ventilator senses that, okay, he is generating a negative pressure of 5 centimeters. Then it starts a flow. You understood? That is pressure trigger. That is pressure trigger. Say if I keep a pressure trigger of 8 centimeters, is it physiological?
Okay.
No.
Why?
Patient has to.
What is the normal pressure you generate for normal breathing?
1 to 2, minus 1 to 2.
Centimeters of water.
How much?
1 to 2 centimeters of
1 to 2
No.
centimeters.
We generate about 4 to 5 or 6 centimeters to have a good tidal volume. See, if you set a trigger of 5 and expecting to generate 5 centimeters, probably if he is capable of doing that in the first place, he should not be on a ventilator, isn't it? If he is capable of generating -5 centimeters of negative pressure, he will generate his own tidal volume.
Yes.
Yes or no? So there is no point in keeping such a high trigger. Trigger should always be 1 to 2 centimeters of water only. Remember this. In fact, studies have proven that improper trigger setting is the reason for 50% of your asynchrony. So in pressure trigger, if you set, what should be the value of trigger setting?
Minus
2 centimeters of water.
-1 or
-2.
-2 centimeters. Why don't you keep it as -5 or -6 centimeters?
Then the patient will have missed breaths, sir. Patient will try to take. Patient will have to.
Yeah, that is what. He may be doing more work. He may be doing more work on a ventilator, isn't it? Because if he is capable of generating -5 or -6 centimeters of pressure, probably he should not be on a ventilator. He is on a ventilator because his breathing is not good. So trigger is very important setting, and it is done only in assisted and supported modes. You don't set a trigger for a paralyzed patient because he's not going to generate a breath, isn't it? You understood why it should be 1 to 2 centimeters?
Yes, sir.
Okay. See, this is flow triggering, meaning there is a small biased flow of about 2 liters which starts at the end of expiration and it goes into the lung. You see here, this part is going, some patient is generated a negative pressure, some air goes into the lung. When air that comes back, the ventilator analyzes. When it sees a loss of some air, then it realizes that patient is wanting a breath. It gives a breath. This is how the flow triggering works. Understood? This, you look at this diagram, look at the thickness of this. A part of it goes here because patient is creating a negative pressure. Only half of it is going back. Then the ventilator senses there is a loss of volume. Then it gives a breath. There also the setting has to be done in liters. That also should be 1 to 2 liters per minute.
Yes.
But this happens only for a very small time. 32 ml per second. We are setting it in minute, but this happens for only 6 milliseconds. So a very small amount goes. When we set 2 liters, don't expect 2 liters to go in. We are setting 2 liters, but the whole process occurs in 6 milliseconds. So about 4 or 5 ml goes in. That's all. In the bias flow, only 4 or 5 or 10 ml goes into the lung, or 20 ml goes into the lung. And patient ventilator realizes when I have given 2 liters, 20 ml is missing, so I will give a breath. Understood? There are 2 types of trigger. One is flow trigger, one is pressure trigger, and both the setting is 1:2. 1 to 2. 1 centimeter of water or 1 liter of water or 2 centimeter of water or 2 liter per minute is the flow triggering setting. Understood? Any doubt? Dr. Anbumani, Dr. Nisha, you understood this? Otherwise,
Yes,
huh? If you have any doubt, I will explain it once again. You tell me.
Yes, sir.
See, you look at the size of the flow here. Part of it goes, only half goes back. So the ventilator will sense there is a loss of volume. So it gives a inspiratory flow.
Yes.
And inspiration sets in. Okay. This is only when patient is communicating to the ventilator. How does the patient communicate to the ventilator to start the inspiration? Either by pressure trigger or by
Float.
Flow trigger.
flow trigger. Understood? What is the value you set? What is the pressure trigger value you set?
1 to 2 centimeters of water.
Flow trigger?
1 to 2 liters per.
Understood?
Yes.
This is very important because more than 50% of asynchrony occurs because of this. And if you set an improper trigger, a patient may be doing more work of breathing on a ventilator, and that is very bad. As I said, if you keep 5-6 centimeters of trigger, then he will not be able to generate that much of pressure, so he'll miss all the breaths. So he'll start fighting the ventilator, he starts coughing, carbon dioxide goes up, respiratory rate goes up, he starts sweating. Most of you go and paralyze the patient. That's what most of the juniors do, isn't it? You should never do that. In a respiratory therapy, paralysis is the last thing you should do. When there is no option, when you troubleshoot and you see that you have exhausted all your capabilities, then only you should go for paralysis. Because most of the times, if you don't set the trigger properly, you go into a asynchrony and patient ventilator fighting. Understood? Okay. So cycling variable, we have already said this. There is only one, both of the cyclings that occur is always either time cycled or volume cycled. You can say the initiation and cycling, if the ventilator is going to control, it is always with time only. You can say it is volume, but again, if you really look at it, it is always by elapse of time. Looking at IE ratio, it will give the tidal volume, and after the IE ratio, I time is done, it will go for E time. So when ventilator is starting a breath or cycling a breath, it is always by the elapse of time. But there is one mode where the patient can control the cycling. Which is that mode?
Pressure support mode.
So what does flow cycling mean? I will explain. This is important. You remember this. See, this is the graphics. See, look at the pressure control. It is time cycle. Volume control. It is, we say it is volume cycle, but it is the elapse of high time that the cycling occurs. So you can say these both are time cycle, and it is always controlled by the patient. And if you look at the graphics here, when time cycling is done, the decelerating flow will touch the time line and then the cycling occurs. This is pressure control mode. This is also deaccelerating flow, but it is flow cycling. You look the difference here. It is occurring much above. Can you make out the difference between these two graphs? The first and the third graph? Both are decelerating flows. But the cycling is occurring above the baseline here. This is flow cycling. When it touches the timeline and then occurs, it is time cycling. I will teach you what is flow cycling, but you remember this when you are standing far. If you see a graph where the decelerating flow touches the timeline, then cycles, you can always say it is a pressure limited mode or a pressure control mode. When it is occurring much above the baseline, you can always say it is a pressure support mode. Because it is flow cycling, it is time cycling. The only why you are little confused is what is this flow cycling? Is what you are not understood. I will teach you that. Once you understand that, you will understand what is flow cycling. It is always controlled by the patient. This is the only mode where triggering and cycling can be controlled by the patient. And if you look at all the advanced modes, almost 70% of your advanced modes are based on pressure support ventilation. Now, your proportional assist ventilation, your adaptive support ventilation, then volume support, then mandatory rate ventilation, mandatory minute ventilation. All these modes are based on pressure support because this is the only mode which gives the control to the patient where he can initiate a breath and he can cycle the breath. He has more comfort. It mimics the normal breathing to a large extent. So most of the newer modes, almost 60% of your newer modes are based on pressure support. Understood? Okay. As I have said, this is to always cycling is by ventilator and elapse of time, and this is by flow. So what is flow cycling? This is flow cycling. See, it estimates the peak inspiratory flow. Say, for example, if your peak inspiratory flow is 40 liters, when the flow starts decelerating, when it comes to 25% of your 40 liters, it goes into expiration. What is 25% of 40 liters?
10 liters.
Isn't it?
10 liters.
When the flow starts dipping to 10 liters, it goes to?
Expiratory phase.
It starts expiration. It opens the expiratory limb and the patient starts breathing out. See, now, see this. If the patient's peak inspiratory flow is 80 liters, when will he cycle?
When the flow reaches 20 liters, it will cycle to expiratory phase.
See, now you have said cycling when the peak flow is 40 liters, cycling occurs at 10 liters. When the peak flow is 80 liters, cycling occurs at 20 liters. That means the IE ratio will change. If the patient is generating bigger tidal volumes, he will breathe for a longer time. So in a pressure support mode, you cannot set IE ratio and respiratory rate. They are controlled by the patient. Only thing what you can set is pressure support, trigger, and the cycling ratio. It is called expiratory trigger sensitivity. It is called expiratory trigger sensitivity. By default, it is set at 25%. It is always set at 25%. See, now, in some instances, if I want to decrease my inspiration, what can I change my expiratory trigger sensitivity to? From 25, can I come down or go up? If I want to shorten my inspiration.
Go up to 50%.
Go up.
If I go up to 50%, what happens to my inspiration?
Inspiration will cut short, sir. It will.
So in which condition you want to do that?
COPD, sir.
Understood?
Inverse ratio.
Any obstructive airway disease, isn't it asthma or anything like that, if you set the expiratory trigger sensitivity upwards, you will shorten the inspiratory time. So when you are ventilating a COPD patient, this is what you have to do. Because you cannot change the IE ratio, because there is no button for IE ratio or respiratory rate. Both are controlled by the patient. As Dr. Anbumani said, if the peak flow patient is capable of generating 40 liters, he will cycle at 10 liters. If he is capable of generating 80 liters, he will cycle at
20
20 liters.
20 liters. So the IE ratio will change breath, depending upon what is his peak flow. You understood how the flow cycling occurs? Any doubts on this?
No, sir.
No, sir.
Okay. So now there are 4 types of breaths. When the patient, when a breath is triggered, limited and triggered by the ventilator, what do we call it?
Controlled breaths.
When all the 3 phases, like starting of the breath, limiting of the breath, and cycling is controlled by the ventilator, what do we call it as?
Called as controlled breaths.
Control
Give me an example.
Volume control and pressure control.
volume control.
And pressure controlled also, isn't it? The patient starts only, you allow only one phase of the, one part of the breathing to be controlled by the patient. Triggering, what do we call it as?
Assisted ventilation.
Assisted control.
When we allow two phases to be controlled, like triggering and cycling, what do we
Pressure
call it?
support. Pressure support.
That is the only mode where we can do it. When all the 3 are controlled by the patient, we call it as spontaneous. Understood?
Yes, sir. Understood.
Okay. So, who can start a breath? Dr. Nisha will take this. Who can start a breath in a situation? Which are the 2 components which can start a breath?
The patient or the
You're okay. How can the patient communicate to the ventilator that he wants a breath?
either with the pressure or with the flow.
You have to specify pressure trigger or flow
Pressure
trigger.
trigger or flow trigger.
Okay. What is the normal values that you set?
If it's pressure trigger, then
Not audible. Anbumani, can you add on that? What is the normal trigger values you set?
So pressure trigger will be -1 or -2 centimeters of water, and the
Okay.
flow trigger should be 1 to 2 liters per minute.
Okay. During the initial part of the flow, which mode is more adaptive? Which mode has more adaptive flow? Tinsel. Either volume control or pressure control.
Sir, if the patient is passive, then
No,
we
I have said that. I have not. I have to ask you a question. During initial part of the flow, which modes have a better flow, which is adaptive to the patient?
pressure limited modes.
Who controls the limit? Dr. Anbumani.
Always the ventilator will
What
control
are the
limits,
2
sir.
limits that we can set?
Either volume or pressure.
Okay. See, it's easy to understand and deduct, isn't it? It's not difficult to understand modes. You have to break it down. See, why I am repeatedly asking you to tell these things is, once you understand this, you will be able to understand all the modes. This is what all the modes are based on. Okay, right. See, now we will see what is set in a volume. What I am setting a volume control mode. What do I set? Volume control. What do I set?
the tidal volume.
Okay.
Right?
Okay. Okay. Then Tinson. Nisha said tidal volume. Response rate. Then.
Tidal volume, keep IE ratio,
Okay. And respiratory rate.
trigger sensitivity also we have to.
Trigger sensitivity in a volume control.
Time triggers.
No. During yeah, when you are paralyzed, you set a trigger. You set a trigger or no?
No, sir, paralyzed patient, we don't have triggers.
Now, what do you see? How do you know the lung is good or bad? In a volume control, how do you assess the lung is good or bad?
Looking at the pressures.
So, what pressures?
If the pressure is high, that means the
What pressure? What pressure, Nisha? You are saying pressure. Which pressure?
So peak pressure, plateau pressure.
How do you measure plateau pressure?
We'll give inspiratory pass for 1 to 2 seconds.
Button. You see, there is a button called inspiratory hold. You just hold it for 1-2 seconds. Then there will be a display here. You see, plateau peak pressure is 30, plateau pressure is 24. It will come like that. Then you analyze whether it is at the beginning of your anesthesia. You check it. If it is 20, if it is 15, in the middle, suddenly if it goes to 20, what is your inference?
The compliance has increased, sir.
Okay, that is what. Yeah, resistance or compliance. Something has happened, isn't it? It may be a kink of the tube. It may be
The
secretion.
resistance has increased.
No, it can be either resistance or compliance. How do you differentiate whether it is resistance or compliance? I taught you last time how to differentiate between how to differentiate whether it is resistance or compliance issue.
Trans airway pressure, that is the difference between peak pressure and plateau pressure is more than 8 or 5 to 8.
Yeah.
Like
you always look at your peak and your plateau pressure. That should be around, if the plateau is more, it is always compliance. If your trans airway pressure is more, it is always resistance.
Resistance.
Understood? These are the settings you put it. So which mode is this? What is the waveform?
Square waveform.
Volume
This is a volume control mode, sir.
Is it assisted or controlled totally?
control, sir.
Because the trigger setting.
Trigger.
Trigger. So this is a
volume control.
Volume control mode.
okay. Who starts the breath and who cycles the breath?
The ventilator.
Both are ventilated. Okay.
Ventilator, everything is ventilated.
If the lung becomes bad, what increases?
Pressure increases.
Which pressure?
Plateau pressure will increase.
Okay. Driving pressure also will increase. Okay. So peak, plateau, and driving, all three pressures will increase. All are interrelated. All three pressures are interrelated. Okay. So in pressure control, what do you set?
Pressure control, we will set the pressure control above, we will set a peak. So pressure control above peak.
Peak, you have to set it to almost. And respiratory rate and IEH for pressure support, you have to set it to almost. So you set a pressure control. And what controls your tidal volume? If I set a pressure control of 18, my tidal volume is 200 ml. How can I increase my tidal volume? Dr. Nisha.
By increasing the pressure, sir.
Yeah. In pressure modes, there won't be a direct tidal volume. You tell the ventilator, you give a flow till the pressure is there. So if the volume is not enough, you increase the pressure. Understood? There is no volume. Pressure is what controls your volume. Pressure limit or pressure level is what controls the volume. Understood, Tinsan? Okay. So which mode is this?
This assisted pressure control.
Pressure.
Why not pressure? Tinsan.
Sir, it is an assisted pressure control.
Why pressure? Why are you? It's a decelerating wave. How do you make a decision it is not pressure support?
Sir, the diesel flow pattern is touching the baseline and it is time cycle.
Touching the
Baseline and it is time cycle. Sir.
yes.
And there is a trigger in the pressure trigger in the pressure waveform, so it is assisted.
Pressure assist ventilation.
Yes.
Understood, Nisha?
Yes, sir.
Anbumani, any doubts?
Yes, sir.
Okay.
No, sir.
See, when you are going from pressure to volume control to pressure control, always check the plateau pressure, volume control, and that is the pressure you have to set for starting your pressure support, pressure control or pressure support ventilation. Understood, Pilsner? When you are changing from volume to pressure modes, always check your plateau, and that should be the pressure that you have to set in that pressure mode, because we are already know for 450 ml we are generating 15 centimeters of plateau pressure. So you put a pressure of that much, you will get 450 ml. We already have that information. Understood? Again, Ask attention. You need
Actually, from changing to volume control to pressure control mode.
when you are changing from volume support, volume control ventilation.
Sir, the pressure control above.
Yeah. Ask.
The plateau pressure, sir.
Yeah, you leave out PP is 5. Above that, you keep 15 centimeters.
Okay.
So that is how you set it. You already have that information in volume ventilation. And you set the same pressure. Don't try to alter there because we already know it is getting 15 centimeters of pressure for generating 450 ml. So your pressure control or pressure support should be 15 centimeters.
Okay.
So what is which is pressure support and which is pressure controlled in these two waveforms? Dr. Anbumani, green one is what?
So that is a pressure support mode because it is a flow cycle.
Very good. What is the red?
This is pressure control mode, sir.
Why?
Because it touches the timeline.
Okay.
It is time cycle.
Very
And
good.
it is decelerating flow, so it is a pressure mode.
Very good. So as I said, in pressure support mode, you can't set the RR. See, this is the panel that you get. You can only support. You can set pressure support, expiratory trigger sensitivity, and trigger. What is wrong in this? What is the wrong setting in this?
Flow trigger is too much, sir. 5 liter per minute.
Dr. Nisha, what is wrong in this panel?
Flow trigger is too much.
Yeah, how much should we decrease to?
Sir, we should reduce to at least 1 to 2 liters per minute.
Okay. See, now I am getting 530 ml of tidal volume. I think it is more. I want to decrease. What is the parameter I will decrease?
Reduce the pressure support, sir.
Okay, Anbumani, you understood that? You don't have tidal volume control here. By altering the pressure control or pressure support level, you want to change the tidal volume. Understood? And there is one more called as rise time. There is something called rise time. It is nothing but the rate at which the flow occurs. If you have a higher rise time, the flow occurs faster and the inspiration gets shortened. So you can have a higher rise time when you want to shorten the inspiration. There are only two settings. The expiratory trigger sensitivity by default is set at what? Always set at?
25%.
Huh?
25%.
25% of the peak inspiratory flow.
Very good, Anbumani. That is the correct answer. Okay, this is expiratory, this is the rise time. So, see here how the flow is occurring. See here, I will show you how the flow is occurring. You see here how the flow is occurring? And you see what I have changed here. What I have shortened here.
Inspiratory time has been shortened, sir.
How did I shorten the inspiratory time? What I have changed?
Flow, the expiratory trigger sensitivity has been increased.
To 52%, so that the inspiration has been shortened. You understand? When do you do this? In which condition do you do this?
In case of COPD.
Asthma.
COPD.
Yeah.
COPD.
Yes. Understood. In pressure support ventilation, there is no control over IE ratio and respiratory rate. You can only change the expiratory trigger sensitivity and rise time and shorten or prolong the inspiratory time and control the IE ratio. Otherwise, patient controls. As I said, if he generates 80 ml of peak flow, his inspiratory time will be longer because it takes more time to deaccelerate from 80 to 20 liters. If it is 40 liters, you will start decelerating very fast. So inspiratory time will be shorter. That is controlled by the patient. So IE ratio we cannot control. But if you want to control, these are the two parameters you have to change. One is rise time, one is expiratory trigger sensitivity. So what is rise time? You see here, what is the time that is required for the pressure to go from 0 to almost 35? This much time it is taking. Look here, it is taking only this much time. Look here, it is taking only this much time. So what I have increased? I have just, if I increase rise time, the ventilator increases the inspiratory flow. But they could have called it as flow. But to confuse us further, they have just put it as rise time. But for your mind, if you say that if I increase the rise time, the flow occurs faster and inspiratory gets shortened. You look at the inspiratory and expiratory times here. See, inspiration is done so fast and you give more time for expiration. Understood? There are only two settings. One is rise time, one is expiratory trigger sensitivity. What does cycling mean? Dr. Anbumani.
Conversion of from inspiratory phase to the expiratory phase.
Okay, correct. Next, types of cycling. It is always time or patient. Ventilator or patient can cycle, no? How can patient ventilator cycle?
It is always time cycle. And if the patient is cycling, it is always flow cycle.
Which mode it happens?
In pressure support mode.
Very good. Which is the only mode where the patient can start and cycle the breath?
Pressure support mode, sir.
What type of cycling is it?
Flow cycle.
In pressure support mode, what can be set?
Rise time and the expiratory trigger sensitivity can be set.
And tidal volume, what do you set for tidal volume?
It is indirectly increased by
Oh, it is okay. Indirectly you increase. What do you set? See, I want
pressure
to give
support. The pressure support can be increased or decreased.
pressure support level, isn't it? This is what you set pressure support. Then you always set FiO2 and PEEP. That is common for all modes. Respiratory rate and IE ratio is controlled by whom? Ventilator or
By the patient.
If patient is sedated, which decreases his effort. Now, if you want to increase tidal volume, what do you change? Tinson, in pressure support mode, suddenly patient is having fever, little restless, you give him a sedation. Tidal volume was 500, it has become 400 now. What do you change? Pressure support is 8.
Increase the pressure supports.
Dr. Anbumani, why are you thinking? See, I had a tidal volume of 500. I gave him some sedation. His respiratory effort came down. It became 400 ml. I had a pressure support of 10. So I want again 500 ml. What should I increase?
Pressure support should be increased.
Yeah, that's what. There is no volume direct control. That is what I am trying to drive home the point. Understood? Okay. Now, last 3 slides, SAV. You are all your good friend, no? You all think that SAV, during mandatory breaths, the patient gets rested and work of breathing decreases. This is your understanding is yes or no? Dr. Nisha, that is your understanding, yes or no?
Yes, sir.
Dr. Anbumani, is that your understanding?
Yes, sir.
Pinsan,
It might decrease the work of breathing.
Pinsan, your understanding?
But actually, it is not like that.
He has learned before, and you think that when the patient doesn't breathe, there is a backup rate. So patient will not go into apnea. That is your understanding. Yeah, I've been teaching mechanical ventilation from 20 years. Whenever I ask the junior colleagues, they always say during mandatory breath, patient can rest. And when he doesn't breathe, there are mandatory breaths. There is a backup rate. This is your understanding, isn't it? So let us see, is it true or false? See, during spontaneous breath, see, your diaphragm is contracting. And you have set a rate of 10. And in between, you can breathe. At every 6 seconds, patient will get a mandatory breath, yes or no?
Yes.
Yes, sir.
At that time, why diaphragm will say, I will not contract now? Will that happen? Will your diaphragm be quiet? Is it possible or not? How does your ventilator know at 6 seconds your breath is coming? It doesn't know, isn't it? You have not looped your brain and your ventilator. So your diaphragm is going to contract irrespective of what breath you are giving. If you are giving pressure support breath also, it is contracting. And if you are giving a mandatory breath also, it is contracting. And see this diagram. What is the ratio here in the mandatory breath, 2 seconds, 4 seconds. And he was breathing at 1 second, 2 seconds. In pressure support, he was breathing at 1 second, 2 seconds. At every 6 seconds, you impose a breath and say that you have to breathe for 2 seconds inspiration, 2 seconds expiration. Will it be comfortable to the patient or uncomfortable to the patient?
It will be uncomfortable.
Dr. Nisha,
It's uncomfortable.
then why do you use SME? See, his diaphragm is going to contract all the time. It is not going to rest. So the work of breathing is not decreased. And suddenly he is breathing at 1 second, 2 seconds. Suddenly you say, now I am going to put a breath which is going to be 2 seconds inspiration, 4 seconds expiration. Will his brain adjust? Will the neural inspiratory time be capable of handling it?
No, sir.
And there are lot of studies which have shown that if you try to wean a patient on pressure support SIMD, it scores last. Weaning is delayed if you put SIMD and try to wean the patient. There is a lot of publications to that effect. So, if you look at whatever way you look at the ventilator, the patient is not having less work of breathing because of mandatory breaths. In fact, his diaphragm may get injured because it after 1 second it starts going into expansion because that is the neural control. The ventilator is pushing more air. So that causes neural, what we call it as a pleometric diaphragmatic injury. So it, rather than decreasing the work of breathing, a imposition of a mandatory breath. You may say it is synchronized. Yes, it is synchronized to his breathing. When it triggers only the mandatory breath comes. But the inspiratory time and expiratory time don't sync with his physiological inspiratory and expiratory time. Because last 2 breaths he was breathing at 1 second, 1 second, 2 seconds. Suddenly, if you say you breathe at 2 seconds, 4 seconds, he can't. That goes into diaphragmatic injury, the increased work of breathing, and also asynchrony. So SIM is a mode which is not very comfortable to the patient, and all your modes have a backup ventilation. If you put a apnea time of 10 seconds, the patient misses 2 breaths, it goes into a backup volume control or pressure control. So there is no advantage in using SIM with pressure support ventilation. See here, his diaphragm is contracting during mandatory breath also. It will not stop. Why it will stop? Tell me. How does it know? If the mandatory breath now I should keep, but it doesn't happen. Okay. Is diaphragm not contracting during mandatory breaths in SMB, or is it contracting?
It is contract.
Continues to contract.
So there is injury and there is no decreased work of breathing. Is that understood? So what is the advantage of using SMB? There is absolutely no advantage. Is Hailey ratio of mandatory and pressure support breath same?
No. No.
Nisha,
I didn't hear, sir.
is the IE ratio for the mandatory breaths and your pressure support breaths in SMB same?
No, sir. No.
So what does it lead to?
What is it?
Asynchrony.
It leads to what?
Asynchronous.
Asynchronous.
Is SMB a good breathing mode?
No, sir.
Why? No, Nisha is
Because
still.
it
Nisha is still.
No, sir. Because it
Why?
increases the work of breathing,
Ah,
it causes diaphragmatic injury,
yes,
and it will be difficult. It takes more time to breathe.
yes, understood. So always go from a volume control, pressure support, pressure control, pressure support, and wean. Don't go for SMB. If you think patient is not capable of being in pressure support, keep him in a pressure control ventilation, assist pressure control. Okay, that's a better mode. Understood? If there is there backup ventilation in pressure support mode if the patient goes into it?
Yes.
Yes, sir.
You can set it. You can either set it as a volume control or a pressure control. So there is absolutely no great advantage in using SMB. Okay. So one by one, what is the first mode? Last slide. What is the first mode? Tinson, which is the first mode?
First mode is volume control mode.
Why? Why did you say
The flow time scalar is flow pattern is a square wave.
okay. What you said? See, I put it here. In all modes, you set FiO2 and P. You leave it. Other than that, what you set in volume control?
Sir, sorry, sir.
In volume control mode, what are the settings you do?
Set tidal volume.
Okay.
Keep I ratio.
And FiO2. Okay. So, what do you monitor?
Monitor for the peak inspirator pressure, plateau pressure, and drive.
Okay, very good. Second graphic. Dr. Angumani, what is that graphic?
It is a pressure assist mode, sir.
Pressure assist mode. Very good. So why did you say that?
So there is decelerating flow, and there is also presence of pressure trigger.
Okay. Nisha, what is the third word?
Pressure support ventilation.
Why did you say it's pressure?
Because the expression starting before the
So it is flow cycling. That's what you mean.
flow cycle.
Okay. Dr. Tinson, what is the last graphic?
That is a pressure assignment.
Pressure SIM. Because there is a pressure deceleration, pressure control, and pressure support both side by side. You look at the V ratios here. The A ratio is different, isn't it? See here, I time, V time, V time. What causes asynchronous?
Yes.
Okay, right. So in the end, if you ask me, which is the best mode to use, it will be my answer. Every mode can be bad if you don't know how to set the settings and if you don't place the good alarms and vigilance. When the things change, you have to go and change the mode sometimes up, down. So whatever mode it may be, you should always look at the settings and then make a decision. And I always say, use familiar skills. Don't go and try an situation first time APRV. Always go with a volume control lung capacity, which is much more safer. So always say concluding that there are 5 modes that ventilate all patients. If you look at all the studies that have been published, they have been done with only those 5 modes. So all the diseases, all the weaning, all the stabilization can be done with the only 5 modes. But there are advantages with advanced modes. If possible, we'll do that advanced modes in the next class. Okay. Now Dr. Sanesh will take over some question and answer session for next half an hour. Dr. Sanesh, over to you, Dr.
Thank you very much, sir.
Satisfy
Been
Dr.
very-
Sanesh and answer properly. Otherwise, Dr. Sanesh will not, and Dr. Radhakrishna will not give you a chance to present next time.
Okay, thank you very much, sir. That was a very absorbing session. And one thing I noted was among the participants, there are many senior faculty of our specialty. Some are my teachers too, and some familiar junior colleagues also listening. And I was happy to view the chat box because some people are very active in the chat. So I thought I'll now give the audience a chance to express their idea with some scenarios. I think I'll take my young friend's help to explain the answer also. So you will get a poll window now for the audience. So select the best answer. Okay. I think the poll window is open now. Identify the mode of ventilation. So far our 3 friends were interpreting. Now it's your chance. Okay, I think more people can vote. These are the scalars we find on the ventilator screen. Scalars means the plot against time. If you see, only the flow scalars have a negative side graph Otherwise, volume, pressure, and all are plotted in the positive side only. So answers: option A, volume control ventilation; option B, pressure control ventilation; option C, pressure support ventilation; and option D, CPAP. Okay. Yeah, we'll be happy if some more people answer, because these are straightforward. I think we have been explaining with the help of graphics for some time. Okay, I'll close the poll in another 5 seconds. Yeah, fine. Okay. So now I'll share the results. I'll ask Dr. Yajni Anpumani to explain the answer.
The answer is volume control ventilation. The
Okay.
first graph is pressure versus time scalar, in which
Okay.
the pressure is the variable.
Okay.
In volume control ventilation, pressure will be the variable. The second is flow versus time scalar. Here the inspiratory flow has square wave. This means that the flow is constant, it's fixed. It's fixed only in volume control mode. So this second graph also denotes it is volume control mode. And the third one is volume versus time scalar. Here the volume is fixed. The tidal volume is set at the same level. So we can say this is a volume control ventilation.
Yeah, basically, we are achieving the targeted volume in all the breath cycles, right? So more than 2/3 people have answered correctly. This explanation is for the people who unfortunately got wrong with this. This flow pattern is classically called as square wave pattern. Okay, and if you can see different breath cycles, the pressure may vary, because when volume is the control variable, pressure becomes a dependent variable. So all these are evident from the graph shown here. Now I think things are clear. Fine. So we'll move on to the next question. Again, I have put a graphic which is much familiar to almost all these students, definitely. Okay, the question is to identify what is labeled here. This is pressure versus time graph. Option A, peak pressure. Option B, plateau pressure. Option C, driving pressure. And option D, auto peak. Yeah, you are expected to answer what is this red arrow marked as P. Yeah, now more people are voting. Yeah, I'll close the poll in another 5 seconds. And I'll request Dr. Tinson. 1 second, I'll close the poll now. Okay, fine. I know that those who are viewing this webinar through their mobile devices, we might get the graphic obscured by the poll window. Sorry for that, it's a technical problem. Let's hear from Dr. Tinson. Dr. Tinson?
Yes, sir.
Yeah.
This is a pressure versus time scalar for a mostly a volume control or a assisted volume control mode. Here we can see that there is a in the pressure graph there is a baseline pressure is always there, that is a PEEP, and when the machine is delivering the volume, we can see the pressure is going up, that is, and it is reaching a peak, that is the peak inspiratory pressure. And at that point, if we apply a pause, that is inspiratory pause for a 1 to 2 seconds, we will get a pressure. That is the plateau pressure. That plateau pressure is the pressure which denotes the end inspiratory alveolar pressure. That is the maximum stress that is applied on the alveoli. And we know that there is a baseline PEEP, that is PEEP pressure. So the difference between the plateau pressure and the PEEP will give the driving pressure. This is the cyclical stress that is applied on the alveoli for every tidal volume delivered to the lung. So we can say that the plateau pressure is the maximum stress, PEEP is the minimum stress, and the driving pressure is the cyclical stress that is delivered to the alveoli every breath. So this driving pressure is very important in ARDS ventilation. We have to keep the driving pressure less than 15 centimeter of try to keep the driving pressure less than 15 centimeter to avoid the volume trauma. That is a indication of the driving pressure. And one more thing, sir, if we have that driving pressure and the volume, we can get a compliance, or if we have the compliance, static compliance with us, and we'll divide the static compliance by this pressure, we'll get the volume also.
Okay. So to make it clear, I think the answer is driving pressure. Okay. The difference marked by this red arrow is the driving pressure, which is the difference between plateau pressure and PEEP. Okay. Unfortunately, most of the people were reaching that answer, maybe because of the labeling and confusion. Many people answered option B, but the right answer is C. Actually, what I meant was the difference between the plateau pressure and the PEEP. Okay. So this is very important when we are speaking about lung protective ventilation, which we will come to in the subsequent sessions, definitely. Okay, I think Dr. Tinson nicely connected it to the compliance also, static compliance also. We'll discuss that further in lung protective ventilation further. Okay. So we'll give, yeah, this is the graphic where this is the pressure versus time. It reaches a pressure peak or peak inspiratory pressure, because different ventilators will have different terminologies, P peak or PIP, that is peak inspiratory pressure. When you give an inspiratory pause of around 1 to 2 seconds, then you get a
plateau pressure,
equilibrated pressure, which is called as plateau pressure. And the difference from the baseline pressure PEEP is the driving pressure. Okay, actually this is the plateau pressure, is the pressure which is actually reflected at the level of alveoli. When you are speaking about barotrauma, plateau pressure was the indicator discussed previously. Nowadays we are switching from plateau pressure to driving pressure. Okay, so that's the thing. Okay, question 3. Again, I would like to listen from the audience. Identify the label P. This is a flow versus time scalar. This is the flow pattern. Okay. This difference noted by the arrow is what I would like to know. Okay, the poll window is in front of you now. Yeah, now the answering pace has improved. Yes, in 5 seconds, I'll close the poll because people are answering very fast and not much clarification required. Fine. Okay. Dr. Nisha? Dr. Nisha, your mic is muted. Yeah.
Hello, sir. Can you hear me?
Yeah, please go ahead.
Sir, the mark of the mark is because the expiration is necessary because some amount of that is because of production of auto.
I think that
Mechanical ventilation, there's no adequate amount of time given for expiration.
Yeah, I'm sorry because there is some audio disturbance. Some audio disturbance is there. And Dr. Anbumani, you want to explain?
The This is
Yeah.
a flow versus time scalar.
Okay.
The answer is auto peep. P
Okay.
here refers to auto peep.
Okay.
And auto peep is due to some air trapping, due to some obstruction.
Mhm.
In this, the expiratory phase will not touch the baseline.
There is expiratory flow limitation, right?
Yes, sir.
Okay. So because of the expiratory flow limitation, there is inadequate exhalation. There will be some amount of air retained in the alveoli by the time next inspiration starts. So what happens is air trapping, right? Intrinsic PEEP. Okay, Dr. Tenson, how do you measure intrinsic PEEP? Though we might discuss in subsequent modules.
Sir, actually, we should make the whatever peep, any peep we have set on the machine, we have to make the peep 0, and then we do an expiratory hold for 2 to 3 seconds.
Okay, like we did the inspiratory pause for plateau pressure. This is expiratory pause. Or most of the machines, modern machines will give you the value straight away. Total PEEP and difference between total PEEP measured and the applied PEEP gives you the intrinsic PEEP. Okay, so this is especially important when you have situations like expiratory flow limitation and some other conditions as well. Okay, we are happy to get some feedback. I think I'll get some quick review from our PG panelists. Okay, volume control mode ventilation, which is the variable component now.
Variable component
Pressure
is
is the variable component.
Okay, fine. So, which pressure is varying?
peak inspiratory pressures, plateau pressure.
Plateau pressure.
Okay, fine. So, this curve we have already explained. Okay, this will also give you some idea regarding the recruitability also. So this is an example where the P plateau is 16 and the PP is 6. So the driving pressure is the difference is that is 10. Okay. So how do you estimate plateau pressure in which mode? Which mode we can estimate plateau pressure?
Only in volume controlled mode we can estimate plateau pressure.
Okay.
That is done by giving an inspiratory hold of 1 to 2 seconds.
Okay. Fine. Is it possible if the patient is spontaneously breathing?
No.
Not possible, sir. Patient
Okay.
should be
Passive. Patient should be passive. Okay. Fine. So this is the difference. Like when the lung compliance is reduced, plateau pressure will go up. If there is an expiratory flow limitation like bronchospasm, the peak pressure goes up. The difference between pressure peak and the plateau pressure is the, what is it?
Trans airway pressure.
Trans airway pressure. Okay.
We'll see how it goes. If we develop temperature. And
Okay, I think this we have discussed already. We'll take some questions from the audience.
Temperature.
One second.
If you send me your home address.
I know there are some questions regarding infant mode and pediatric mode that we'll discuss in a separate session. Okay. Then actually we have explained regarding P ramp and rise time. That has already been explained, like the fastness or quickness with which the pressure variable comes to the peak is called P ramp or rise time. Okay. If the slope is faster or steeper, the rise time is shorter. Okay, the concept of checking the plateau pressure while changing from volume control to pressure control, actually. There was a question regarding that. Basically, to put a patient on, start a patient on pressure control ventilation, what you do is you empirically give a pressure control value and see for few breaths how much is the volume generated. If you are not happy with it, increase in small equals of 2 or 3 or 4, depending on the target tidal volume attained. Before that, you should have an idea how much is the volume you are going to target. which is also important, because you will not be targeting a 10 ml per kg like we are taught conventionally, because we can't imagine that a person of 5.5 foot stature is having a smaller lung or a bigger lung when he is 100 kg and a smaller lung when he is losing weight to 60 kg. It doesn't happen like that. So roughly, depending on the body surface area and all, we can estimate that length or height is one of the determining factor, because somebody gains weight and becomes obese, his lung is not going to improve. So roughly you target around 6 to 8 ml per kg of predicted body weight. If you have problem with measuring the weight in your ICU, measuring tape is good enough. If you measure, you will have rule of thumb formulas available, so that we can get the predicted body weight and calculate the tidal volume required. Then further titration we can do with the blood gas values and all. So that is one thing. You should have an idea how much is the volume you are going to target. Second method is, you know how much tidal volume you are going to target, put the patient on a volume control mode, get a plateau pressure, and then use this plateau pressure as an indicator to plan your pressure control. So I was taking the questions from the audience. That was regarding why do you check the plateau pressure while changing from volume control to pressure control? Yeah.
That's what Sabai, as Sunny said, already are giving a volume, but we know what is the pressure being generated in the ventilator, and you use the same ventilator, so the volume will come. They're related, isn't it? There is no rocket science. We are giving a volume, that's the pressure generated. If you keep that pressure, obviously that volume will come.
Okay. And
Okay.
I think there was a query on driving pressure. I think we have addressed it along with our graphic.
Better in ARDS when we drive.
Yeah, we'll discuss further. Should SIME mode be out of ventilator?
Yes, that's what is our. We'll go with time. It will go with time.
No, just because one mode is in the ventilator, we are not compelled to use it.
No, it will go with time. We have it's a lot of people use it. The companies are doing it.
Mm-hmm. I think there are not much questions. You have already answered in the Q&A session, like assisted breath, what happens in SIME plus pressure support mode.
Yeah, answered it.
Yeah, okay, fine. So I think we had a good discussion regarding our basic modes of ventilation. I think we have revised on ventilator graphics also to a great extent, because we can't discuss these concepts without the help of graphics. And Chandrasekhar sir has good slides to teach you how the graphics appear. And it's my request to all the junior colleagues that whenever you start a patient on mechanical ventilation, you look at the parameters, not only the set parameters, the monitored parameters also you should look into. The graphics appearing on the screen you should be checking, and you will also get some pressure volume loops and all, which will give you characteristic shapes, or scooped out appearance when during bronchospasm, expiratory flow limitation and all. So you keep your eyes open when you are in the bedside with the patient. So take all the clues, then you need not study hard on these topics, because these are everything you are going to see on your ventilator screen whenever you are with the patient in your ICU. Only thing is, you should take pain to be with the patient and see how the trend changes. Because ICU topics, you can't be having a recipe like one size fits for all. Every time it's going to be dynamic. Patient condition keeps evolving. You need to listen to the alarms, and to troubleshoot the alarms, you should know how this happens. So that also is important. The more you try to interpret and get things corrected from your faculty, the more experience you will be becoming. And of course, some of the problems you need a technician to come and sort out. That time your option will be to change the ventilator. So like that, ICU learning, especially with mechanical ventilation, is fun if you know the basics and you spend time with the patient and ventilator. Radharshan sir, any remarks? Sir, your mic is muted.
Thank you, Dr. Chandrasekhar. Dr. Sanish, and thank you all the panelists who were with us. And I'm sure you are able to learn more on the mechanical ventilation today, and probably through the next 2 sessions. Well, you may be able to analyze and play with the ventilators from now onwards. And do you want to talk anything further, Dr. Chandrasekhar, now?
Thank you, sir.
Yeah. Dr. Sanish,
Um,
you want to
um,
talk anything on today's
no,
webinar?
Jayashree ma'am is with us. We'll take some remarks from ma'am also.
Yeah.
Good evening, everybody. And as we had the last time, excellent lecture. And I think the basics have been really appreciated by the students, as we can see in the chat box. And when I meet my students tomorrow, they always appreciate what has been taught. So basically for the students, it is the basics which you must understand. And once you get to know these, then your whole management becomes easier. And congratulations to the students who took part in this. You all did a very good show. And all of you read again and clear your doubts. Thank you.
Yeah, actually, I'm very happy that all the 3 postgraduate panelists, they were very active throughout the session. Next week, we'll be having respiratory physiology module 2, where we'll be discussing on ventilation, perfusion, and the relationships, how anesthesiologists should be interpreting these changes expected and encountered during your practice, and lecture by Dr. Pankaj Kundra on oxygen and carbon dioxide transport. The first lecture by Dr. Shobha Philip, and the second one by Dr. Pankaj Kundra. That's the webinar waiting for us next Wednesday. Thank you, Chandrasekhar sir.
Any questions remaining in the chat box?
We have answered, sir, most of them.
Most of them you answered.
Yeah.
Okay.
And
So,
this video will be available in our YouTube channel, IC Academics, from tomorrow morning onwards.
So we can close the session now?
Yes, sir.
Yes, yes.
Okay. Thank you and good night to all. Thank you.
Thank you very much. Good night. Good night.
Thank you, sir.